Aussie MedEd is proudly sponsored by eMedici, an Australian-made medical education platform for med students, junior doctors and IMGs. Whether you're preparing for your med school exams, the AMC, the specialty training exams, or looking for CPD to stay sharp on the wards, eMedici offers thousands of MCQs, clinical cases, OSCEs and mock exams to help you study smarter and build real clinical confidence. To learn more, visit emedici.com/meded. Pregnancy. It's common, it's natural, and yet it can turn complex in a heartbeat. So what should a straightforward pregnancy look like? When should a GP relax and when should alarm bells ring? What tests actually matter and when do you induce? And how do you balance birth plans with real-world risk? Today on Aussie MedEd, we're cutting through the noise on the management of pregnancy from their very first booking right through to delivery and postpartum care. Joining me today is obstetrician Dr. Alison Munt, and we're getting practical. We're talking referral thresholds, gestational diabetes, hypertensive disorders, growth restriction, and what GPs and students really need to know when pregnancy stops being low risk. If you've ever wondered, am I over-referring or am I missing something, or what's actually standard practice in 2026, this episode is for you. Welcome to Aussie MedEd. G'day and welcome to Aussie MedEd, the Aussie-style medical podcast, a pragmatic and relaxed medical podcast designed for medical students and general practitioners, where we explore relevant and practical medical topics with expert specialists. Hosted by myself, Gavin Nyman, an orthopaedic surgeon, this podcast provides insightful discussions to enhance your clinical knowledge without unnecessary jargon. I'd like to start the podcast by acknowledging the Kaurna people as the traditional custodians of the land on which this podcast is produced. I'd like to pay my respects to elders both past, present and emerging, and recognising their ongoing connection to land, waters and culture. I'd like to remind you that all the information presented today is just one opinion, and there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live. Well, joining me today is Dr. Alison Munt, a specialist obstetrician and gynaecologist practicing in Adelaide and based at Adelaide Obstetrics and Fertility in Goodwood. She completed her obstetrics training in 2013, and her approach emphasises the importance of informed consent and individualised care. For medical students and GPs, Alison brings a wealth of experience in the full spectrum of pregnancy management, from antenatal care through to delivery and postpartum support. Welcome, Alison. Thank you very much for coming on Aussie MedEd.
Thanks for having me.
Perhaps we could start off by asking you to describe the typical presentation of a healthy singleton pregnancy.
No problem. So I guess from my perspective, I'll typically see patients for their first antenatal visit by about 10 weeks. But often these patients have been seen by their GP, usually between about 6 to 8 weeks for their initial antenatal visit. And the first visit with the GP is important for a number of reasons, and they usually will rock up with an idea about their gestation based on their last menstrual period. But obviously that visit is super important to determine their estimated due date and whether that can be calculated from their last menstrual period or whether they need a dating ultrasound scan. But the other reason why that visit's important is for basically looking at models of care for that patient and what's suitable. So it's good for the GP to determine that, and to do that, they should really be looking at a comprehensive health history of the patient and also examination just to see if it's a low-risk pregnancy or a high-risk pregnancy, what the patient's preferences are for ongoing pregnancy care in terms of models of care. Calculating the due date, which is very important, and obviously examining the patient, which at that stage is just a general examination for general well-being, and then routine health testing as well, just screening for some initial blood tests that are really helpful to have when I see a patient perhaps for their first visit at 10 weeks. So with the history, like I said, the first thing that you're probably wanting to determine is how far along the patient is. So determining the due date is about determining the first day of their last menstrual period. And most women these days planning a pregnancy will have that really reliably recorded in their tracking app, which has been very helpful over the years to have that. You want to also determine their past obstetric history, which when you're trying to determine risk factors, just a general medical history or even family histories are very helpful too. And then substance use is something that you'd want to determine at that first visit as well. When you're looking into substance use with the patient, obviously it's about educating at that point probably as well. At the first visit, it's very important, and referring on to different programs might be helpful for women who perhaps are smokers or drinking alcohol at that point. In terms of clinical examination as well, one of the most important things is determining BMI, and that's a really important risk factor to help determine what best model of care for the patient is. And then blood pressure as well. So booking blood pressure is key in pregnancy, just to determine how that tracks from there. And even something as simple as white coat hypertension at such an early gestation is really important to determine risk as well. It's probably the case that GPs tend to be seeing patients at an early stage where you're not going to be able to palpate a fundus of the uterus. However, if we were beyond that first trimester, that would be something that you could perhaps do, or auscultate a fetal heart. Or if you were lucky enough to have an ultrasound, obviously an ultrasound at that point is a good idea. A general examination of the cardiovascular system is important, and then a breast examination probably at that point is always something that you should consider at that early stage. When you go on to consider some investigations, routine blood tests that we would expect at a first visit would be pretty simple, things like a full blood count to look at hemoglobin and platelets. We would like to know what the ferritin level is, or iron studies. A very important test is obviously the blood group and the antibody screen, which we would want to have done at this early stage. And then some viral serologies, and the routine viral serologies that we do include rubella, syphilis, hepatitis B, C, HIV as well. And depending on risk, and this is something that doesn't necessarily need to be done at this stage, we may screen for other infections like CMV as well, which can be important as well.
On those points, what are you looking for on the breast examination?
I guess it's probably just determining breastfeeding, like if we're anticipating moving into lactation and breastfeeding, if we have a baseline examination to know, are there any pre-existing lumps or bumps? Because as someone moves into that lactation stage and breastfeeding stage, obviously we expect to have some lumps and bumps. So it's always good to just have a baseline examination, because it's easy at that early stage to get an ultrasound and just manage what needs to be managed, or at least understand what's going on, rather than leaving it till later in the pregnancy.
What concern about CMV? I mean, I have very poor recollection what that involves and how you catch it. The
risks of acute primary CMV, particularly in the first trimester, there's significant risks to the fetus with that. You catch it from toddlers basically. So invariably parents who already have toddlers probably have had exposure to it, to be honest, or usually caregivers of toddlers, so people who work in childcare, teachers who work in primary. So they're the people that are probably most at risk of CMV. And I guess preventing CMV is really about hand hygiene, not sharing spoons or cutlery with your toddler. And it's one of those things that we don't necessarily routinely screen people for it because of the difficulty in interpreting results or managing results and doing anything about it, I guess. But for the higher risk people who we would like to know, are they immune or do they have active IgM, then we would do that, because it might change outcomes in terms of counselling moving forward in the pregnancy, given the risks of acute primary CMV. But yeah, it's a difficult one. The recommendation at this stage is not to routinely screen.
And that can affect brain development predominantly, was it?
Yeah, so it's basically torch syndromes, developmental issues, microcephaly, and just generally sort of poorer outcomes for the baby. So another association is hearing deficits and visual deficits as well.
Right, now this is the pathway that a GP would go down when they first see a patient who's pregnant. But when do they refer to an obstetrician?
So this is where I guess the GP's helpful at helping the patient determine what model of care the patient wants, because there's certain different types of models of care, which includes GP shared care, then private versus public care, and then midwifery-led care through the public system. There's not really a role for midwifery care privately at this stage, or there's gaps there at the moment in terms of how that's supported by Medicare. But once the GP, I guess, can determine risk, because a high-risk pregnancy, we would encourage medical care, and that could either be through public or through private. So most patients will, I guess, present to their GP at that 6 to 8 week mark. And at that point, we want to, as long as we've got some reliability behind determining the due date, there may be a role for the GP in terms of also determining the intrauterine nature of the pregnancy. So if there were any concerns at that point around bleeding or anything that just wasn't quite right, or pain, then it would be the role of the GP to make sure that an ultrasound was ordered and some bloods were ordered to confirm an ongoing intrauterine viable pregnancy. So in the setting of a threatened miscarriage, that GP would on-refer in a more urgent setting, I guess, to a women's health unit, either in a public setting or to a private obstetrician who usually would make time to see that patient more urgently to manage what needs to be managed. But in the setting of a healthy, well pregnancy that's determined to be intrauterine, no other major concerns, then that person may not be seen again in public until after the first trimester. So often it would be the role of that primary caregiver or GP to determine or to organise those first trimester screening tests. However, if that patient chooses private obstetric care, we would normally like to see the patient more closer to the 10-week mark, where we can counsel the patient around some of those early first trimester screening tests that can be done as early as the 10-week mark. In terms of midwifery care, that sort of level of triage usually occurs after their first booking visit in the public sector, after they've seen a midwife, and they usually get an extensive history taken, and then depending on the preferences of the patient and suitability of the patient, they'll be triaged either for medical care or for midwifery group care. And that's usually how that sort of evolves.
Excellent.
We'll be right back.
I'd like to let you know that Aussie MedEd is sponsored by Heidi Health, who provide Heidi AI transcription platform. The team at Heidi have told me that Heidi is the AI scribe built in Australia and trusted in nearly 2 million consults every week. The Heidi team have told me that students and trainees get free access to Heidi Pro, which they believe will aid quicker, smarter notes, allowing more time for patients, learning and rest. To learn more about the Pro account, visit heidihealth.com/pod. So let's say the patient sees the GP and the GP determines it's a low-risk pregnancy. Is a per-vaginal examination required nowadays, or can a lot of that be done through a ultrasound and other investigations? And also, what's the role of also urinalysis as well, looking for abnormalities in that?
Yeah. Well, just going back to, I guess, the vaginal examination, I guess there's some indication, depending on age of the patient and last STI check, to do that sort of screening that we recommend in women. And similarly, to make sure that they've had HPV testing or cervical screening. So they're two important things that usually we would expect to be done, either in a pre-pregnancy setting or, if not done in that time frame, in that first trimester. However, a general vaginal exam wouldn't necessarily be indicated. In terms of assessing, though, with ultrasound, we would normally, for that first ultrasound, do a transvaginal ultrasound, as that's more accurately able to determine gestation and get more reliable images and measurements of the crown rump length. That would be something to perhaps expect with your first scan, particularly if it's before that sort of 10-week mark. The second part of your question, Gavin, was about urinalysis. So we would normally send as a routine, which I think I didn't mention was a midstream urine at the first visit. That's really just as a baseline looking for asymptomatic bacteria, because we have a low threshold for treating any bacteria in pregnancy, as it can escalate and become something more overt more easily. So we do tend to treat with antibiotics. So we would do that at a booking visit. And then more often, if we had a patient who was perhaps more high risk for UTIs or has a history of recurrent UTIs. But I wouldn't routinely these days be screening for proteinuria, which is something that in the past has been something that we used to do. We're more inclined to send a protein creatinine ratio for patients who are at risk of any renal issues or blood pressure issues or, anything we're concerned about. But dipsticking the urine isn't something I do day to day in my private practice. And it's probably something we still do though in a public setting for presentations, but more probably to look for if someone's presenting with urinary symptoms for nitrites more than anything.
Right. So it sounds like generally the first trimester is pretty easygoing. It's more of a checkup and screening. I presume there's also some advice you give about diet as well. You've already talked about the importance of not smoking and drinking alcohol.
The general advice is that no alcohol is safe. But I think what you don't want to do, though, is add too much anxiety to patients, particularly, at that first visit. A lot of patients might have drunk in the first trimester inadvertently. So I'm not going to sit there and sort of be like, oh, that's terrible. What have you done to the pregnancy? Because it's so common for people to inadvertently drink in their pregnancy. And we haven't, over my 15 years in private practice, found any issues with that if it's a one-off drink. But yes, we do advocate that no alcohol is safe. I was just going to say, because I guess that goes back to the nutrition part of it as well, because historically we used to weigh patients every visit as well, which is not something that I would do anymore either. For the same reason, I think it adds anxiety to patients watching their weight go up. And generally it's patients who are eating healthily and eating a balanced diet. But the nature of pregnancy is that you are going to most likely, and most people will, gain weight. And the amount of weight that you gain is really dependent on your starting BMI. And people with a BMI over 40, in fact, I'll expect to lose weight often. So it's such a broad range and it's so individualized that if I have patients that generally eat a balanced, healthy diet, I'm not going to be on their back about their weight, but I'll be supportive of people who are worried about gaining too much weight. And we have great women's dietitians. And obviously weight gain in pregnancy is probably important from a risk of gestational diabetes. But once again, that's where we get people to dietitians to sort of manage that risk if we needed to.
Well, on that basis, what is the risk of gestational diabetes? What percentage of women will get it? And how do you actually treat it?
So it's probably more common than you think. And we would probably diagnose around like 10% of our pregnancy population. It can be diagnosed as early as the first trimester, right through till the usual screening test for low-risk patients, which is at 26 to 28 weeks. Recent screening has changed. As of last year, there's new criteria based on what's the ADEP's recommendations. And so it's a bit harder to get diabetes these days, which patients appreciate. So the fasting and 1 hour and 2 hour levels have increased, which is a good thing. And I think the changes reflect that we were diagnosing it a lot and we found that probably the diet that people then took on with the diagnosis was quite restrictive and perhaps having adverse effects on the pregnancy, not eating enough, and how that impacted the pregnancy. So the criteria has changed, which is good. But what we do recommend in people with risk factors, and risk factors include previously having diabetes, weight, family members who have had diabetes, We would screen usually at the sort of 14 to 16 week mark with a glucose tolerance test. We also are pretty routinely doing a HbA1c on most patients just because it's an easy test to do with the booking bloods, which I didn't mention and we wouldn't necessarily expect the GP to do, but I have noticed most patients rocking up for their visits with a HbA1c, which is helpful because it would trigger a change in management if it was at a certain level. So like I said, the HbA1c, the GTT at 14 to 16 weeks in the higher risk patients. For low risk patients, a routine screen at the 28 week mark. And when we diagnose it, we would refer the patient for diabetes education and dietetics input about a diabetes diet. And most often and a lot of the time, these women can manage their blood sugar levels with diet. They will be encouraged to monitor their levels basically 4 times a day, so fasting and then postprandial 3 times a day. And as long as they maintain certain levels, diet will be the key, and that's a lot of the time that's what it is. Sometimes patients will need medical treatment, and that can be metformin or insulin, and that sort of depends on the patient preference. And we'll have the support often of our obstetric physician. We have an obstetric physician in our rooms who sort of helps us if we need it.
We'll be right back.
I'd like to let you know that Aussie MedEd is sponsored by Better Medical. Thinking about your next move as a GP? Better Medical has clinics across Queensland, South Australia, Victoria and Tasmania, offering you the freedom to practice your way and backed by a strong support network. With dedicated teams across IT, marketing, HR and finance, the team at Better Medical feels this allows the GP to focus on delivering great patient care while retaining full clinical and billing autonomy. Visit bettermedical.com.au today to learn more. Right. Well, obviously, the person who is at high risk or is developing gestational diabetes will go down the path of dietary advice. But what about for the average person? What other advice would you give, like for folate, iodine, vitamin D, other things you might suggest as well?
Yeah, so there's definitely some supplements that we recommend, and some we recommend pre-pregnancy as well. And most people are familiar, obviously, with the recommendation around folic acid to reduce the risk of neural tube defects. And we sort of, encourage or recommend that for at least a month pre-conception and then throughout the first trimester. And we also recommend iodine as well. So most pregnancy supplements will come as a package with the 500 micrograms of folic acid and then the iodine to go with that. Similarly, the advice around vitamin D has changed a little bit. I think most people are vitamin D deficient, to be honest. Rather than screening these days, the recommendation is just to have supplement vitamin D. I think it's about 400 international units. And once again, that's usually what comes in these pre-pregnancy vitamins. So that usually includes the vitamin D. We'd normally do some targeted screening for things like iron. And so sometimes women will need to supplement early in the first trimester their iron. Other things like just considering people's diet on an individual basis, whether calcium is adequately covered in their diet, because we would replace that if we had concerns about that. Similarly, for vegans or people, who don't eat much meat, we're looking at things like B12 as well. That often might need to be supplemented. So there are a few additional things. I'm thinking there's a lot of noise at the moment around things like choline, I think. A lot of patients ask about that. In a balanced diet, we shouldn't necessarily need to supplement choline. However, once again, often that does come in pregnancy supplements. And I think the one I forgot to mention as well that is important is omega or DHA. We do routinely screen for that now. There's been, SAMRI have run a trial recently looking at omega levels and risk of preterm birth. And we know that certain levels are recommended in pregnancy. So with the first trimester screening that I do, I'll look at omega levels to see if people need to take an omega supplement as well.
The other thing too I was reading up about was the importance of exercise. Well, that sounded like hard work because I think the recommendation is for the average person is 30 minutes of exercise 3 to 4 times a week. But when you're pregnant, they're suggesting it 30 minutes every day, which on top of everything else you're doing, how can you fit all that in?
Very much. I mean, I think once again, it goes back to adding more anxiety, and there's so much anxiety or things to be anxious about for if you're a new time mum. I wouldn't routinely be encouraging people to do anything different to what they normally do, particularly in the first trimester where they do not feel like doing anything. However, I think that advice is generic advice, probably based on the obesity epidemic and perhaps, just trying to get people fitter for their pregnancy and delivery. But from my perspective, I wouldn't discuss that level of exercise or change people's exercise regime outside of what they normally do. In saying that, there is some benefits to things like pregnancy Pilates and just staying mobile and making sure you're stretching and things like that we know can help for labour and just put someone in a good position for their labour and also for their recovery. So as I go in the pregnancy, I would figure out who might be suitable for that or if that's something that they would be looking at doing. But I think staying active, doing the normal level of activity you would normally do is what I would recommend. And obviously just reconsidering any contact sports as you enter the second trimester as well, just for obvious reasons.
Yeah. When is morning sickness the worst? Is that in the first or second trimester?
Look, I guess morning sickness is probably peaking around that 8-week mark as your hormones are peaking. And most women will find that they will be free of those symptoms by about 16 weeks. And it just starts to improve between that 8 and 16-week mark. A small percentage of women have persisting nausea in pregnancy throughout the whole pregnancy, which really is unfortunate because, it's a long time to feel sick. But there's obviously things that we can do to try and manage that and alleviate those symptoms. But that would be the exception. Most people would find, that 16-week visit, everyone's feeling pretty good, not too big, not feeling really pregnant anymore. But it's just that very few number of people that have that persisting nausea.
So what's the monitoring stage after that? Do they have to have further follow-up ultrasounds or other tests done as well?
Yeah, and I think I haven't mentioned a few of the earlier tests that are really important. There's obviously the non-invasive prenatal test, which is the 10-week blood test that we offer now that can look at risk of Down syndrome and look at it pretty reliably and more reliably than the traditional combined first trimester screen, which was the tool that we used to use to determine risk of Down syndrome or aneuploidy in the pregnancy. Now we have a full genome non-invasive prenatal testing. So it can look at a full karyotype of the baby. So it can pick up any rarer chromosomal abnormalities as well as look at risk for Down syndrome. It looks for sex chromosome abnormalities, so things like, obviously, like Turner's or Klinefelter's, we can look at that. And for people who want to know the sex of their baby, that can be determined at 10 weeks, which is amazing. So that, I know it's craziness. So that is as early as the 10 weeks. The test that I would normally do, the results are available within 5 days of that. And then we also can't forget about the carrier screening testing that we can do now, genetic carrier screening testing, which I also offer all my patients in the first trimester. But GPs can offer that, and the earlier it's offered and done, the better, because it takes a few weeks for the results to get back. And it's probably a better test to do pre-conception. And there's now a 3-gene carrier screening test that's offered by Medicare bulk billed. There is an extended genetic carrier screening test that we can offer as well, which I always offer, that looks for about 600 recessive genes. But that test is still about $1,000. So not many people are doing it, and probably a better one to reserve for pre-conception, just given the counselling that can be involved with any abnormal results. But the 3-gene test is definitely worth doing, and that involves looking for the cystic fibrosis gene, the spinal muscular atrophy gene, and the Fragile X gene, so 3 recessively inherited conditions. So that's always helpful to have as well when I see patients for their first visit. Yes.
So those tests are done just as blood tests of the woman that's pregnant, is it? The ones looking for the infant or the fetus carrying a abnormal gene is a blood test as well from the woman, or how is that done? Because in the past it used to be amniocentesis, but that must be out the window now.
No, so essentially the non-invasive prenatal test is detecting fetal DNA. So it is the fetal DNA that's picking up. And the reason you can't do it before 10 weeks is because there's not enough fetal DNA to detect. So we wait till 10 weeks, and that tends to be the right time, and we have enough fetal DNA so that we can get results. So that is essentially, looking at a full genome of the baby. We can offer that at that early stage. When we're looking into morphological abnormalities, that's when we, even in the setting of doing the NIPT test, we would still recommend a first trimester or 12 to 14 week scan as an early morphology, because that's sensitive at picking up morphological abnormalities even at that early stage. But it's always followed up with the 20-week morphology scan, which is where they can finally sort of have an assessment of things like the heart and the spine, which can't be done as early as 12 or 14 weeks.
Right. So that means there's a scan done by the obstetrician or GP, just as a routine ultrasound scan in the 10-week, and then there's 2 morphological scans at, did you say 14 weeks and 20 weeks? Is that correct?
Yeah, so I would normally do 13 weeks, if that's what I do. It could be as early as 12 or as late as 14 to 16. And that's just, like I said, I think the importance of that is being potentially picking up some abnormalities at an earlier stage than leaving it till 20 weeks. But then the final scan at 20 weeks is still performed, like I said, to get the final views of the heart and the spine.
We'll be right back.
I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. 2 of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au. Just going back a step, we're talking about fetal DNA in the woman's bloodstream. Has that always been known? Yeah. Because I wasn't aware that occurs. I always considered the placenta as being almost like 2 different areas meeting, and there was transfer of oxygen and nutrients, but not as much DNA. And if that's the case, what stops the baby being rejected by immune system as well?
So by the fetus, I guess I mean the package of the fetus and the placenta. And this is where the NIPT isn't 100% reliable. So you can have some mosaic abnormal genes where the placenta's involved, but it doesn't involve the fetus. And that can be difficult to interpret on the NIPT. And that's where, even with the high-risk NIPT result, we would still do a diagnostic test. So it's considered an advanced screening test. So it's still not considered to be absolutely diagnostic. And if we did have a high-risk result because of that small chance of mosaicism or the placental cells, then we would refer for an amnio, which is considered a diagnostic test.
Right. And so it's still done the amniocentesis then?
We still do it, and that's because we need, sometimes if we have concerns around aneuploidy, we might need to look at a microarray, which you can't get from the non-invasive prenatal test. Right. So that's looking at whole chromosomes, whereas if we're concerned about genetic abnormalities, we need to go delve a bit deeper, and that can only be done through a microarray chromosomal assessment, which can only be done through diagnostic testing, which is by taking fluid from around the baby. Or alternatively, you can do the chorionic villus sampling, which is where you take the tissue from the placenta.
Right. And so after the 20-week period, there's no further ultrasounds required unless an abnormality develops?
Yeah, depending on risk factors. In my practice, I scan everyone every visit, because we have the technology and it's so useful for me to confirm presentation and also to do a sort of quick growth assessment or estimated fetal weight assessment. But obviously in the setting of the public hospital or midwifery-led care or GP shared care, you're not going to necessarily have that at your fingertips, but you would measure symphysiofundal height, You would also get an idea about, size and whether you thought baby was small or large for gestational age, and that might trigger a third trimester ultrasound to get a better idea about size of the baby. Keeping in mind that ultrasound is plus or minus sort of 20% at being accurate for determining estimated fetal weight, so it's not 100% reliable by any means. And then also there could be patients with other risk factors that would trigger a formal scan being ordered to look for estimated weight, or AFI, so fluid around the baby, and umbilical artery Dopplers as well. And that could be if someone had a risk factor like hypertension or diabetes, any autoimmune conditions, any previous history of an intrauterine growth restriction. So that would be a trigger for definitely for a third trimester scan. And often it's more than one because it's more interval growth rather than a one-off growth assessment, because obviously there will be big babies and small babies, and it's more about how babies track in that third trimester. And as long as they're tracking along the appropriate centile line for them, then that's what we want to see. So it'll often be a couple of scans if there are any concerns around fetal growth.
Right. What about those other tests too? This must be showing my age. You probably don't even have them anymore. Those old-fashioned sort of look like bells that you put up the abdomen and try and listen to the fetal heartbeat.
Pinard, yeah. So I remember starting training, and I used to have a couple of my consultants still using Pinards when I started training. We've come a long way. We know.
And fetal ECGs, are they called CTGs? What are they?
CTGs, cardiotocograms. So yeah, we still use them a lot actually, and it helps us determine fetal well-being, and we do it both antenatally but also intrapartum. So it's the most important tool intrapartum to sort of determine the fetal well-being. So any pregnancy or labour where we have concerns around that would get fetal monitoring, which involves the CTG. And then some people antenatally, there might be an indication for an antenatal CTG just as another sort of check off for fetal well-being. And that could be as simple as a mum who's got concerns around fetal movements. And usually at 20 to 24 weeks, I'll educate patients about what to expect so that they know what to look for. But once again, that's another sort of point of anxiety for a lot of people. And in a low-risk pregnancy, I don't necessarily encourage people to count kicks or count movements on a daily basis, because that's just can do your head in. And everyone will have a different experience with their baby's movements, and it's really what they know to be normal for them. And then if it deviates from that, that's when we can sort of intervene to reassure with the CTG. So that would be one of the primary indications for an antenatal CTG. But another reason would be if we've got concerns around growth and we're doing regular growth scans, that would be another sort of thing that we'd do in between just to make sure baby's happy.
So what are the things that really trigger your concerns? Watch out from the second trimester versus the third trimester then.
Yeah, well, I guess, look, it's so dependent on the individual patient and whether they have underlying risk factors. So I guess I've already in the first trimester determined risk for things like preeclampsia at 12 weeks, another test that we can do where we can determine the patient's risk of developing something like preeclampsia. And the way we do that is by looking at placental growth factor, which is just a placental protein that we routinely measure in the first trimester. So it's a measurement that we've had available for a while. We use that along with mean arterial blood pressure and a few other characteristics of the woman, including like BMI, history of previous pregnancy, and then family history to determine a risk of developing preeclampsia later in the pregnancy. So that sort of testing that we do now routinely at the 12 to 14 week mark will then change management as well, because often if someone's high risk for preeclampsia, we recommend low dose aspirin in pregnancy, so 150 milligrams daily. And we also want to make sure that they have adequate calcium intake. And if they didn't, we would encourage a calcium supplement. We know that those two things can reduce that person's risk of preeclampsia. it's at that point, things like autoimmune conditions are going to be a factor that we're going to be considering as well as increasing that risk. And once again, I've talked about the assessing for risk of diabetes at that mid-trimester stage also. The third trimester is really about, I guess, monitoring the patient at each visit for things like blood pressure, but also for other symptoms as well associated with high blood pressure in pregnancy, including swelling and obviously things like headaches and abdominal pain and things like that. But they would be the things that we'd be monitoring along with obviously the size of the baby, which I've mentioned how we would assess for the size of the baby in the third trimester.
How often would you see them then in the third trimester? Is it still weekly or is it every fortnight?
Yeah, so for women in their first pregnancy, once we sort of get to 28 weeks gestation, we normally recommend a 2-weekly visit. So we sort of escalate the visits at that point because before that there would be monthly visits. But from the 28-week mark, we really want to keep an eye on things that I've mentioned like blood pressure, but also that's when, the growth of the baby really becomes obvious where the smaller babies stand out from the bigger babies. And we expect a certain amount of growth each week. So we should be able to measure that and see that, which is usually around the 200 grams a week. So it's really from that 28-week mark that the 2-weekly visits are quite important. And we'd normally do that up until around 36 weeks. And then from 36 weeks, we would normally see patients weekly until delivery, depending on when that is, which we don't know, which is the annoying part about my job.
Yes, the unknown. Of course, that's not always the case because sometimes there's planned cesareans and planned inductions as well. How do you determine which way someone will go? Certainly in a standard simple pregnancy, they've obviously got a few different options. And other times in the more complex, it might be a bit harder.
Well, it's generally in a low-risk pregnancy with no indication to deliver early, I'd normally base it on patient preference, and as long as they make the decision well informed. I guess a lot of the time in the first pregnancy, a patient who's aiming for a vaginal delivery will also want spontaneous labour. And often that's probably because of misinformation around induction of labour. But in saying that, from my perspective, I think, induction of labour can just be a bit harder for the patient because you're in hospital longer. And as soon as you get to 2 days in hospital trying to have a baby, it gets a bit of a drag. So I kind of agree and would encourage for a first-time mum to perhaps wait for spontaneous labour, understanding that might not come and you might get to your due date and beyond that and it still might not come. And that brings with it some risks that I would want the patient to be aware of because essentially the most recent data probably supports 39 weeks as being the optimal time for the baby to be born. So the baby does not need the mum or the placenta anymore beyond 39 weeks. And then we know that risks after 40 weeks, including stillbirth, meconium, stained like, or caesarean section rates, all increase quite significantly. So it's about balancing those things with the mother's or the patient's preference for spontaneous labour and their birth plan. But for women, and I find in their second pregnancy, most women will elect to be induced at 39 weeks because they kind of know what it all looks like. And I think induction is probably a bit more predictable in the second time pregnancy because we know that induction will be a lot quicker and we can predict a bit better how the mum's going to go. And she already knows what labour's like. The fear around a failed induction is minimal. The fear around needing an emergency section is minimal. So often that's how it looks. First time, waiting for spontaneous labour, making sure they're well informed about the risks of that versus a second time mum just coming in and probably locking in a 39-week induction. In terms of risks of induction, I guess I mentioned the misinformation, and it's difficult because there's so much information out there these days, and unfortunately I think sometimes there's too much, and most people have been pregnant or know someone who's been pregnant, so have an opinion on it, and it can get it very confusing and overwhelming when someone's trying to make a decision. And I find that even with evidence-based advice, people can still get a bit confused and overwhelmed with it, which is understandable, especially if it's your first pregnancy. But yeah, essentially induction of labour is very safe. The risks associated with it would be failed induction, but after 39 weeks, that's very unlikely. Hyperstimulation or overstimulating the uterus, but that can be managed very easily. It's not a concern. And it's a very safe option for mum and baby, but probably with an increased rate of pain relief or epidural, and not because it's more painful. And I think that's one of the misconceptions, is that it's a more painful experience. I think it's just probably how it brings on contractions. It's just a little bit artificial and it can be a bit more sudden. So it's less of a build-up where your body can gradually get used to it, and it can just be a more sudden thing, which leads to probably more requests for epidurals. But also because you've been in hospital longer, so it just, it's a bit of a mental game, labour, and I think that does your head in a little bit, and therefore you're going to go down that give me an epidural path, probably a bit easier. But ultimately, very safe, a safe option if needed or if wanted.
What about the role of caesareans then? Is that kept as a sort of emergency scenario or when the delivery is not progressing, or is it also still done electively as well?
It's definitely done electively, and in my practice and most people's private practice would be offered as a very reasonable, safe option for maternal preference as well. It's 2026. We know we can do caesareans really safely. It's a very predictable outcome and predictable way to have your baby, and it's also a very safe way, but obviously that's taking into account recovery and just understanding what that looks like. But these days that's a reasonably manageable thing as well. But I would say that would be something that most obstetricians these days would offer to anyone who would like to, for instance, they don't even need a reason, but often women would like to protect their pelvic floor. A lot of the time it's as simple as they're not motivated to labour, and I think that's fine too. Like, labour's a lot. It's unpredictable. From my perspective, I can't, from one person to the next, say how long it's going to be, even what the outcome's going to be. And some people don't even want to go into a labour knowing that it might end in a caesarean, and they prefer to go, you know what? I'd prefer just to have a predictable caesarean section. So I think motivation's the key. I'm not going to be the one to motivate people for a labour, but if they want it, I'll be there to cheer them on, and we can do this. And if it's suitable, absolutely 100%. But motivation, protecting pelvic floor, are two reasons why people might choose to do an elective caesarean. And I think that's not unreasonable in this day and age. The main probably risks is over time, if it's repeat caesareans, the risks of, a placenta accreta or scarring. But in the setting of one or two caesareans, it's not a concern of mine.
Talking about the pelvic floors, I know that there are women's health pelvic specialist physiotherapists who can talk about antenatal and postnatal sort of treatment to try and prevent incontinence and other issues, prolapses that can arise as a complication of pregnancies. First of all, a big issue as a complication, is it something that occurs regularly? And also, what's the role that a physio has to play both antenatal and postpartum?
Physios and women's physios are super important, and we have physios in our rooms who specialise in pregnancy care and women's health as well. And most of our patients will see the physio during the pregnancy, and that's to either prepare for their delivery, whether it be vaginal or caesarean. And then they'll see them at a postpartum visit to help with their rehabilitation, which is something that's traditionally done really poorly because women have babies, they get very distracted with their baby and then don't invest the time in rehabilitating from pregnancy. So there's probably two areas of recovery, which is from the delivery or mode of delivery, but also from the pregnancy, which is it's a recovery in itself. You've just grown a human. A lot has happened to your body during that time that relates to both your pelvic floor and your core muscles. And you do need specialist women's physio advice on how to recover those things. And and like I said, I think we just haven't done it well in the past, and that's just an education thing. I find that's a really important thing to encourage women to invest in. In terms of, I guess, pelvic floor damage in pregnancy, or even like perineal trauma in pregnancy, which is another fear for a lot of women. They don't want stitches in their vagina. they would prefer to avoid it 100%. I think my advice is that aiming for a vaginal delivery, your first delivery invariably 90% of the time will involve some perineal trauma, but most of the time that can be managed with good preparation and a good person involved in the delivery to help manage the delivery. And we now recommend managing labours. We're back to a bucket of hot water and a compress. So we know that data supports using warm compresses in labour to prevent perineal trauma or reduce perineal trauma. So that's sort of gone full circle. That's something that we definitely use. But also preparing for the delivery with perineal massage is something that we encourage our women to do from 34 weeks. And that advice and education is provided by our women's physios who know that stuff back to front. They will usually do a 34-week assessment of the women's perineum and pelvic floor muscles, and then basically give advice around how to do the massage, but also to prepare them for pushing. So labour, you sort of might think would be intuitive when you're second stage and you're pushing, but it actually isn't. And it's a weird thing that sometimes women need to have some guidance with that to actually push properly or effectively. And we find that educating women on how to push properly at that early stage can be really helpful. And that's advice that, like I said, our women's physios give at that stage as well. In terms of damage to pelvic floor, such an unpredictable thing. And I think it's sort of one of those things that is probably mainly based on genetics and, you know, how good your connective tissue is. Because some people will push out a 4.5 kilo baby and do it 5 times and have no issues. And some people will have 1-2 kilo baby and then have issues ongoing around pelvic floor dysfunction. And it's just an unpredictable thing. And it's hard for us to manage through the delivery and how we can help. It's really just, it's luck of the draw, unfortunately. But I guess it's about that management afterwards. It's that rehabilitation after your pregnancy. People who go back to back with pregnancies don't do proper pelvic floor rehabilitation. They're obviously going to be at more risk of having ongoing issues. So I think, yeah, women's physio is really key to my practice and looking after my pregnant women.
Right. And of course, throughout this whole process, I believe midwives are involved in the care of the woman throughout the 3 trimesters, but also, most importantly, during the delivery as well.
Oh, absolutely. I guess depending on the model of care will depend on how involved a midwife is in your pregnancy care. And the public hospitals will offer midwifery group practice care, and you can be directed towards that. And that's where you'll see a midwife throughout the pregnancy and obviously a midwife for the delivery as well. For a private practice model of care, we have midwives in our rooms, and our patients who we see regularly here will see the midwife every visit because they are invaluable at providing their insight into pregnancy care. And then they will also be involved in the delivery and then postpartum care as well. So we have our lactation specialist, and she is able to see our patients from early postpartum at the 1 or 2 week mark. That's sort of where things are hitting the fan a little bit when it comes to breastfeeding or settling, and she will offer advice around how to improve that. And yeah, she's invaluable. But throughout the pregnancy, like I said, our patients are seen every visit by the midwife. Once you go into labour, most of the labour, even in the private setting, would be managed by the midwife with deferring to us. But the first stage of labour will be managed by the midwife, for instance, at their private hospital, and they're very important in the patient's care at that time. And often the delivery, if you are delivering in the public setting, will be done by the midwife who's caring for you, unless there's any concerns around the labour where they would involve one of the medical officers at that stage. But I think this also highlights some, deficiencies, I guess, in care of a pregnant woman. I think antenatal care, traditionally, the focus is on that, but the postpartum care has been quite deficient, especially when it comes to lactation support or mental health support. And that's why we've sort of incorporated our eligible midwife, which is people who've done some additional training, and they're able to provide care and provide scripts if needed. And yeah, it's just very helpful in that sort of that postpartum period that we find. And similarly, that leads on to the mental health side of things. We try and support our mums with assessing whether they need any additional help with perinatal psychology, which we have here, and also a GP in-house who can provide a mental health care plan at the last minute if needed as well.
Excellent. Well, do you have any final thoughts to add to the medical students or GPs listening in?
Well, anyone interested in women's health as either an RMO or even intern should consider the certificate in women's health or even the diploma through RACGP, because both of those things are super important in general practice, but also for regional care of women and whether you do pick up even GP obstetrics. So totally encourage it. We need more people doing sort of things like that to support women's health.
Brilliant. Well, thank you very much again, Alison, for coming on Aussie Med Ed. It's great to have you on board.
No worries. Thanks, Gavin.
I'd like to remind you that the views and opinions expressed in this episode are those of Dr. Alison Munt and reflect her personal clinical experience as a busy private practicing obstetrician, informed by over a decade of prior work as a visiting medical officer in the public health system. Obstetric and perinatal care involves clinical complexity and individual variation. There are multiple evidence-based approaches to the management of pregnancy, labour and the postnatal period, and what is appropriate will vary depending on the patient's circumstances, local guidelines, resources and clinical expertise. The content of this episode should not be taken as the only acceptable standard of care, nor as a substitute for individualised clinical judgment. This podcast is intended for educational purposes for medical students, junior doctors and general practitioners. It does not constitute medical advice, and listeners should refer to current clinical guidelines and consult with appropriate specialists when making clinical decisions. Thanks again for listening to our podcast, and please subscribe for the next episode. Until then, please stay safe. I'd like to let you know that Aussie Med Ed is sponsored by Avant Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.